Excuse me. Yeah, the YouTube live is on now.
Okay, sir.
So I'm going to make you the host again. And I'll log out of this session.
Okay, sir.
Yeah, any questions, you can just ping me in the WhatsApp. I'll log back in.
Okay. Okay.
Thank you. All the best.
Thank you, sir.
Thank you.
Hello.
Hello, I can hear you.
Yeah.
I think it's 9 o'clock. Shall we
Yeah.
start?
Yeah. I think we shall start.
Okay. Good evening, all. This is Dr. Guru Sandhya. I'm one of the faculties from the Global Anesthesia Society, who we are guiding and helping the people who are preparing for EDAIC II examination. And this is just the first session of faculty Mock Viva, where the faculties, myself, Dr. Gurikpal, and Ashwini Kumar sir will be assisting you or will be showing you how the Viva is conducted. As per the Viva, it is actually conducted as 25-minute session for 4 sessions each. And the first 2 sessions are from the basic sciences, and the third one is from the clinical anesthesia, and fourth one is for ICU topics and the images or chest X-ray and sorts, and for the scoring systems. So from today, the classes from yesterday, the classes have started, and today is just a faculty mock demonstration. And if anyone has any doubts, you can ask it now regarding how the sessions are conducted. And in case of an online exam, you will be given the question 5 minutes before the examination, and you can have 5 minutes of time to draw the diagrams or to recollect the points, whichever you want to say. And once when the session starts, they will actually start with the specific question which they have asked you first, and then they'll move on from that. They'll move on to next question, and it keeps on adding to as many questions as you answer in the sessions. And for every session, there will be a basic question from which they start, and they'll move on to the next one. In that, if the basic sciences, they'll try to cover as many systems as possible, and they'll assess you your knowledge in all the topics per se. Suppose you say they have given you only oxyhemoglobin dissociation curve. Regarding that, they'll ask only for 5 minutes. Then the question will jump from that to the next question, and it keeps on adding. If at all you don't know the answer for any particular question, it doesn't matter. We just have said that we don't know, and they'll skip to the next questions or so. Gurikbal, would you mind to say some words or your experience in the examination?
Yeah, it's like they, as you said, they keep jumping on from one topic to another topic, and it's better if you don't know any, answer to any question. It's better to say that sorry, I don't know, because the time is very limited. Because it's hardly 12.5 minutes for each, for each examiner. So you have to like quickly jump on to the next question, and they will just show you one question initially in the one slide where you have to note down and write your answer in probably 10 minutes, and then they will take you to the examiners. Like there'll be 2 examiners per session, and they will be asking you the questions depending on which session it is. First 2 are basic sciences, physiology, pharmacology, anatomy. Next, third is clinical anesthesia, and fourth is critical care medicine. So yeah, that's it. I guess you have to be thorough with all the questions and what you're going to answer.
Yeah, Ashwini sir.
Yeah. So yeah, it's all the same. What you people have already explained well how the exam is conducted. So just to add on, my colleagues just said, they will be asking the main topic, which question is there in the paper, which you will be preparing for the initial 5 minutes. Then they will be asking about that. From there, then they will start jumping from that topic to another topic related or maybe not related to that. And they keep asking questions. My one piece of advice, which I think helped me, was from my seniors or the people who cleared the exam before me, was if you don't know the answer and if you're like really blank, just skip the answer so that there will be enough time for them to ask the next questions, rather than just cooking up some answers, because that will only waste your time. So it's better if you don't, because we are all human beings, so we can just forget some things at that time. So just skip that at that time and then go for the next question. Maybe you're lucky in the next question. And just by skipping one, that will not fail you for sure.
Yeah, that's what I told it. When I really didn't know the answer, I said, sir, I don't know the answer for this question.
Exactly.
And then I moved on to the next one. And that next one had the question which I can really answer for.
Exactly.
It's not, one question doesn't make you fail in the examination. It's the collective wrong answers, or it's the collective answers which we don't answer really make us fail. Otherwise, it's okay. But they concentrate more on the basic sciences in this exam. But if you like fail to respond to their very basic questions like oxyhemoglobin dissociation curve or carbon dioxide transport, then we are held responsible.
There's a marking system, like 4 sessions. Each session is of 20 marks, and there are 2 morning sessions, 2 evening sessions, and you have to get a minimum of 60 out of 80 to pass the examination, and 25 in each session, morning and evening, to pass the individual session. But collective score should be more than 60 or at least 60 to pass the examination.
Yeah.
In the online examination, just 10 to 15 days before the examination, they'll send you a mail regarding, some of us might have got 27th to 29th October. So they'll mail us regarding which date we have got, and they'll have a rota also regarding which time we have to be online and all that. The session will be for 25 minutes, but before half an hour before that, we should log in. And the session will start like exactly some 10 minutes before, so that they give you the question. After that, there will be break. Then again the next session. So we have ample amount of time in between sessions to where we can go relax ourselves and come. Then they ask definitely for a ID card, maybe passport. Most of us had a passport, and they specifically ask for a headset like this, or one which Dr. Gurigbal is wearing, and they'll ask you to show the room as well. And they'll have a mock examination, which is a must for attending. And if they ask you to draw in the examination, they have all that modules where you can go and draw, or where you can point a particular abnormality in a chest X-ray or so. So all those will be told to you in the mock examination, which they provide dates for, and we can attend it in any convenient date. It's must to attend it just because you will get used to how the online examinations are conducted. And for each session, before each session, they'll check our rooms. For it is not necessary to change anything in our rooms, just that there must be a table, and on the table there must be nothing except for a piece of paper where we can draw or show anything to the examiners. And we should have only the IDs, the passport or Aadhaar card for any Indians, and it should be legible as well. And when you get it close to the camera, it should be legible. If it is not, they'll ask you to show it again and again. Since they must recognize that it is us who are attending the examinations.
Okay. So I had attended the exam before the COVID issues had happened. So I had to literally go to the place. So the centers were in Europe. So when we finalize the center, just take some time just to see where exactly the center is going to be. So try to take a lodging near to the center so that you minimize your travel to the center. And there the exam started in the morning, like as Dr. Gurisandhya said, they will give enough time between each sessions, even in the offline time. So you will have enough time to take a break between the sessions. So first it was like they take us to a room where they will give us this question and ask us to prepare ourselves for 10 minutes. Then we will be taken to another room where the examiners will be sitting, and a number will be written on the table which corresponds to our chest number, and we have to go to the table. 2 examiners will be there. Each examiner will have 12.5 minutes, so total 25 minutes, and they are very, very particular with time. So they just abruptly stop as soon as the time finishes.
Yeah.
So that was my experience with the exam. Okay,
and
so I
also
think
they also expected us to draw diagrams whenever it is necessary, like for volume of distribution or any competitive agonist or antagonist, oxyhemoglobin dissociation curve, shift to right, shift to left, and all those diagrams from Emma Plunkett are must to read.
Yes, and actually during our session, actually, I was not asked to draw a single diagram, and one of my colleagues has also, sit in the exam a day before. He was also not asked, so the trend might change. Like it may vary from time to time. Sometimes you are asked, sometimes you are not asked. But during online Viva, there are like less chances that they asked to draw.
No, in my session,
diagram.
My question was about compare oxyhemoglobin dissociation curve with carbon dioxide dissociation curve. So literally every one of us drew, and we showed the paper to them in the examiners, and they said, okay, you've drawn.
Okay.
And all the examiners are very, very pleasant, and they will not at all try to push you or anything. So so it's a very, very calm atmosphere. As far as I knew, that's what I had felt.
Sometimes they keep giving hints.
Yeah.
And if at all you don't understand their language or pronunciation, how do they pronounce, and you can actually ask them. They say the onus is on us. If you do not understand the question, and ask us again. So I had asked an examiner for a question thrice, and he repeated the question until I understood what was the question was. And then it's kind of difficult, their accent and our accent, so it differs. So if you're not understanding the question, you can very well ask them to repeat the question and then take the question, like, once you've understood it.
Yeah.
Okay. Sarvari ma'am, yes ma'am, yes ma'am, I just saw you
so
just now.
Agree with you totally, because what happened is I gave my exam in Germany, in Langen. So around 50% of examiners were taking exam only in German. For some students, so the language was, to understand English, it was a bit difficult, but but they absolutely cooperate with you, and they give ample time, and even the funny thing was they offer food, and I mean, it was coolest exam conducted, and the diagrams were actually expected on basic sciences table, and the clinical tables, it was offline. I think I did not have to use the paper and pen, but the other two tables, it's better for us that we should quickly take paper in our hand, so that we ourselves can give better answers. That's what I thought there. Yeah.
Okay, ma'am.
So shall we start with the sessions now?
Yes.
So the first session, I'll be acting as an examiner, and Dr. Guru Sandhya will be acting as an examinee. So shall we start?
Yes. Are we clear and audible to all of you?
Yes.
Yes, you are clear.
Okay, ma'am.
Okay. So shall we start?
Yes.
So Dr. Guru Sandhya, tell me and classify antiarrhythmic drugs.
Antiarrhythmic drugs are used to control arrhythmias, and there are 4 classes according to Vaughan-Williams classification. Class 1 is a sodium channel blocking agent. Class 2 is beta blockers. Class 3 is for potassium channel blockers, and class 4 is for calcium channel blockers. And class 1 is further classified into 1A, 1B, and 1C. 1A drugs include quinidine, procainamide, and diazopyramide, and 1B drugs include lidocaine and mexiletine, and 1C drugs include flecainide and propafenone. The class 2 drugs, which are beta blockers, include esmolol and propranolol and metoprolol, and class 3 drugs, which are potassium channel blockers, include amiodarone, sotalol, beryllium, and imidazolide. And class 4 drugs, which are calcium channel blockers, include verapamil and dilsum. There is also other classification, which is a modified classification of antiarrhythmic agents given in Circ journal. It is it includes class 0 to class 7 agents, and it also includes class 0, which is a HCN modulator, and class 7, which is a mechanosensitive receptor modulators.
Okay, tell me about amiodarone.
Amiodarone, it is an antiarrhythmic agent. It is a class 3 antiarrhythmic agent. It is a benzopurone derivative, which has 37% iodine by weight. And the mechanism of action includes, as I said earlier, it is a class 3 antiarrhythmic agent, which is a potassium channel blocker. Hence, it prolongs the effective refractory period of all cardiac tissues, which includes SA node, AV node, bundle of His, and Purkinje system. And it has also got an anti-adrenergic effect. It is a non-competitive antagonist at alpha and beta receptors. Given at a dosage of 150 milligram bolus, followed by 1 milligram per minute infusion for 6 hours, and then it is given as 0.5 milligram per minute for 18 hours in case of an atrial fibrillation. It is also given in the ACLS guidelines for VT or VF. It is a refractory VT or VF at a dose of 150 milligrams, and it is also available in the oral form as 200 milligram tablets. And it is coming on to kinetics and dynamics. It has got a prolonged elimination T-off of more than 20 days, and it is metabolized extensively in the liver to I just forgot what is the metabolite, and it has got an extensive protein binding, and it has got a very large volume of distribution, and interacts with cytochrome P450 enzymes, and it inhibits them, and hence it leads to increased plasma levels of digoxin and warfarin, and hence their levels and dosage should be adjusted according to the levels which are monitored according to INR in case of warfarin. And the side effects of amiodarone includes pulmonary toxicity, which is of two types. It is a pulmonary alveolitis basically, and one type is of slow onset, which leads to infiltrates in the chest X-ray where the patient has a chronic cough or so. But the other type is an acute onset where the patient in the postoperative period can present as pulmonary edema. The other side effects include corneal microdeposits, and these microdeposits does not cause any blindness per se. They can also cause neurological manifestations as peripheral neuropathy and liver toxicity in case of mild transaminitis. And these transaminitis, and hence these patients who are on oral amiodarone should be monitored for LFT for at least once in 3 months. And since amiodarone is 37% iodine by weight, it can either cause hypothyroidism or hyperthyroidism in susceptible patients, and hence TSH also must be checked once in 3 months. And in case it occurs, the management has to be treated accordingly.
Okay. Tell me about adenosine.
Adenosine, it is also an antiarrhythmic agent. It is an endogenous nucleoside, and the mechanism of action is it targets the adenosine A1 receptors in the cardiac tissue or in the AV node. And the action of adenosine is kind of quite similar to the calcium channel blockers, which are there available as verapamil and dilsum. And it hyperpolarizes the cell membrane, cardiac cell membrane, and it causes the prolongation of the refractory period, and it slows the impulse across the from the SA node to the AV node. The available form is 12 milligram or intravenous preparation, and it is also being used in the intrathecal preparation, which I have not used personally. And the dosage is around 6 milligram IV push for any supraventricular arrhythmias which are seen. And if it is not reverting within 3 minutes, if it is stable, then the dose can be repeated with 12 milligram IV bolus for supraventricular tachycardia. And the duration of action is only for 10 seconds, and hence it must be administered as a rapid IV bolus. And in case of kinetics, since it's like metabolized very rapidly, and given as an IV bolus, it causes intense headache, flushing, and dyspnea or intense chest discomfort in a conscious patients, because it is given only in a patient who are stable and conscious. And it is also known to produce bronchospasm, though the mechanism is not known yet. And one interaction which we must remember during giving adenosine is that methylxanthines, they actually inhibit the action of adenosine, whereas dipyrimidamole, which is an adenosine reuptake inhibitor, actually potentiates the action of adenosine.
Okay. Tell me about vecuronium, its mechanism of action, pharmacokinetics, and dynamics.
Okay. So vecuronium is a competitive neuromuscular blocking agent. It is an aminosteroid group of agent, and it is an agent which has an intermediate duration of action. It is a monoquaternary compound and an aminosteroid compound, and the available as a lyophilized powder, either as a 4 milligram or 10 milligram vial, and any preparations which are diluted or not that stable, and hence it is provided as a lyophilized powder. And it is the ED95 dose of vecuronium is somewhere around 0.04 milligram per kg, and the intubating dose is around 0.1 milligram per kg. And the mechanism of action is the competitive blockade at the post-junctional receptors where the acetylcholine acts, and it competites with acetylcholine. Only when there are 75% of the receptors are blocked with vecuronium, the block will be effective. And when stimulated with the neuromuscular stimulation, there is a decreased pitch height, and the train of 4 amplitude is decreased. There is tetanic fade, and there is post-tetanic facilitation. And these drug, when given IV, it is metabolized in the liver and extensively in the liver, and it is only 30 to 40% in somewhere around in the range it is excreted via the kidneys. The metabolites include 17-hydroxy, 3-hydroxy, or 3,17-hydroxy vecuronium. And in case the 3-hydroxy vecuronium, all these metabolites have a prolonged duration of action, and hence this vecuronium cannot be or should not be used for any patient who has got an infusion or say. And these lack the vagolytic properties as in case of pancuronium, and these vecuronium is case of a cardiac stable drug, and hence preferred in cardiac surgeries, and lacks histamine release, and hence can be administered in a patient who has got acute asthma, asthmatic or drugs like atracurium can cause histamine release, but vecuronium does not have that property. And it is it's a neuromuscular blocking agent used for surgeries where neuromuscular blockade is essential. And in case it is available as a lyophilized powder. That's also.
Describe various uses of epinephrine in anesthesia.
Epinephrine is an endogenous sympathomimetic agent. It is used in the ACLS guidelines for shockable rhythm as well as non-shockable rhythm at a dose of 1 milligram per kg every 3 to 5 minutes. It is used as an ionotrope in case of a shock, or also in case of ionotrope for weaning from bypass, where the myocardial contractility has been increased, or where the also used in the ACLS guidelines for the bradycardia protocol, where the bradycardia is not responding to atropine at a dose of 2 to 10 mics per minute. And it is used for the treatment of refractory bronchospasm or severe asthma, which is not controlled with the long-acting anticholinergic agent or steroids. And it is used as a treatment of choice for the anaphylactic shock, as in 50 mics bolus to 100 mics bolus, as well as infusion in case of an anaphylactic shock. It is mixed with the local anesthetic agents to enhance a vasoconstrictor property and to decrease the systemic absorption of the local anesthetic. And it is also used in the that's all. I'm not able to remember any other uses of epinephrine.
Okay. So tell me about dexmedetomidine.
Dexmedetomidine, it's alpha-2 adrenergic agonistic agent. It is imidazoline derivative, and it is an enantiomer of medetomidine, which is used in the veterinary surgery for very long years. And it has got a selectivity of alpha-2 receptor somewhere around 1600:1. Alpha-2 to alpha-1 is 1600:1. That is the ratio in which it is highly selective. And that is the mechanism of action. It's an agonist. It is available only in the IV preparation of 50 mics, 100 mics, and 200 mics vial. And it is given at a dosage of 0.5 mics to 1 mics per kg, depending upon the level of sedation or analgesia which we must achieve. It is given at a dose of 0.1, 0.5, or 1. And even 3 to 4 mics per kg have been documented to have good amount of evidence even for 3 to 4 mics per kg. And it acts in the central nervous system to produce sedation, which is similar to the natural sleep, where the patient will be aroused even from the patient gets aroused as if it's a natural sleep. And analgesia is mediated by its action on glutamate and substance P. And it also there is no respiratory depression per se with dexmedetomidine even at higher doses, but there is decrease in minute ventilation, but there is no effect on oxygenation or carbon dioxide dissociation curve, or the ventilatory response to hypercarbia persists with dexmedetomidine. And in case of CVS, it causes hypertension, where when the initial bolus is given very rapidly and large doses are given. The other effects are hypotension and bradycardia because of the sympatholysis. And it is used in ICU for sedation, and it is used in anesthesia for non-operating room anesthesia, where the respiration must be preserved, as in case of MRI, or in case of bariatric surgery, where an awake fiber optic is used. Bariatric surgery as an opioid sparing agent. This has become an adjuvant which is very promising in opioid sparing surgery, opioid sparing anesthetic technique. And it is also used for sedation in awake FOBs because it does not cause any respiratory depression. And sedation in ICUs, there has been decreased incidence of delirium with dexmedetomidine per se. And it is it undergoes complete biotransformation in the liver, and the liver disease actually impairs with the metabolism of dexmedetomidine. And in renal elimination, because of it is extensively protein bound, and because of renal elimination, this actually has an effect because of the protein binding alone in renal elimination. But when the creatinine clearance is more than 30 ml per minute, renal disease does not cause any any effect on the dexmedetomidine effect. And the contact sensitivity half-life is somewhere around 4 minutes for a 15 minutes infusion, and 250 minutes for an 8-hour infusion per se. And the side effects are hypotension and bradycardia, as I mentioned earlier. And that's all I can remember of dexmedetomidine.
Okay. That's all for this session. Thank you.
So that's how the Viva session goes. They jump from one question to another. like even before you finish answering, they may actually jump on to the next question, but doesn't mean you haven't answered properly.
To a totally
shall I be sharing?
unrelated topic.
Yeah. Okay. So now I will be the examiner, and Ashwini Kumar sir will be the examinee, and we shall start the next session. So just a moment. So here we will start with a question which comes as, sir, you're ready, right, Ashwini sir?
Yes, I'm ready.
Okay.
I'm ready. Please.
Okay. So,
Thank you.
90-year-old male found collapsed at home in the bathroom, incontinent of urine and feces. He complains of severe pain in the right hip with shortening and rotation. His son, who is a sole caretaker, contacted him 2 days back. Upon arrival to ER, his GCS is somewhere around 13/15. BP is like 80/60. Heart rate is around 74. Respiratory rate is 32, and saturation is 94%. Upon doing an ABG, his pH is 7.23 and potassium is 9. And his past medical history includes hypertension and congestive heart failure. He's on treatment with enalapril, spironolactone, and metoprolol, and his ECG showed just a minute. This. Okay.
Okay.
Legible?
Yes.
Okay. I'll stop sharing the screen.
Okay.
Just a moment. So, Dr. Ashwini, what can you see in the ECG?
So in the ECG, we can see tall tended T waves, and there's
Okay.
a loss of P wave and very broad QRS complexes. And looking at the arterial blood gas, the potassium is 9, the pH is 7.23. Looking at the history of the patient, he had a fall and he was on the ground for more than 48 hours, which is a cause for probably muscle injury, rhabdomyolysis, and that can lead to hypokalemia. And from the ECG, it's evident there are the typical changes for the which suggestive of hypokalemia.
Okay. So what are the causes of hypokalemia? Can you enumerate them?
The causes can be broadly classified as excess in exogenous intake of potassium, and that is like potassium supplements, excess in diet or salt substitutes, or excessive endogenous potassium load, that is like hemolysis, rhabdomyolysis, as in this patient, extensive burns, intense trauma, and tumor lysis syndrome. And another cause is the redistribution, that is shift from the intracellular to the extracellular. As we all know that potassium is a major intracellular it is mostly in the intracellular fluid. So when a redistribution happens, like for example in the acidosis, insulin deficiency, drugs like succinylcholine, beta blockers, digoxin, or in the familial periodic paralysis. These are the causes for the redistribution hyperkalemia. Other causes are like the decreased potassium excretion, like in case of chronic kidney disease, renal tubular acidosis. Then there are certain drugs which causes decreased excretion, like the non-steroidal anti-inflammatory drugs, ACE inhibitors, or potassium-sparing diuretics like spironolactone, which is again the case in this particular patient. Then there is a condition called pseudohypokalemia, which we get false results from the lab due to the hemolysis in the lab, or due to thrombocytosis or leukocytosis or venipuncture.
Okay. So can you enumerate what the signs and symptoms of hyperkalemia?
Usually in hyperkalemia, the patient will be very lethargic. There can be confusion, decrease in the GCS. There can be weakness. Flaccid paralysis can be seen, and generalized muscular weakness can also be seen. And yeah.
Okay. Can you tell us what are the ECG changes in case of hyperkalemia as this patient is covered?
The ECG changes in hyperkalemia correlates with the serum potassium level. So any value above 5.5 is considered to be hyperkalemia. So the normal value is from 3.5 to 5.5. Anything above 5.5 is considered hyperkalemia. So we can divide it as per the serum potassium value. So 5.5 to 6.5, we start seeing tall tended T waves, which we can see in this particular ECG. Then from 6.25 to 7.5, there will be loss of the P wave, and from 7.5 to 8.5, there will we can see, along with the tall tended P waves, there will be broadening of the QRS complexes. And any value above 8.5, the QRS complex becomes very broad and it approaches the sine wave.
Okay. How about managing hyperkalemia in this patient?
Okay, managing hyperkalemia is very important because it's otherwise it can cause sudden cardiac arrest and even death of the patient. So managing hyperkalemia should be the first and the foremost priority in any kind of patients, especially in this particular patient. The treatment of hyperkalemia can be targeted on three things. One is on stabilizing the myocardium to prevent arrhythmia. Second is to shifting of the potassium back into the intracellular space. And third is removing the excess potassium from the body. Now, starting with the first, that is stabilizing the myocardium. For this, we use calcium. The commonly used calcium is calcium gluconate, 10% we give. It takes around 15 to 30 minutes, the action. And we give around 5 to 10 ml. We give it slow intravenous. Calcium chloride can also be used, which is 3 times more potent than calcium gluconate, but at the same time it causes irritation, especially when we administer through the peripheral venous lines. Its dose is also around 5 to 10 ml. So generally, but we use calcium gluconate to treat to stabilize the myocardium. And
any role of yes,
yeah,
sir?
please. Yeah.
So what are the complications of calcium administration?
So calcium again. So as I said, it should be given in a very slow intravenous. The complications of calcium can be bradycardia, peripheral vasodilation, and hypotension. So it has to be monitored and given as a slow intravenous. In conditions where hyperkalemia is occurred due to digoxin, it is better to avoid calcium, and rather we can go in for magnesium.
Okay. Do you know any other measures to control hyperkalemia?
The other measures to control hyperkalemia are like shifting the potassium back into the intracellular space. So that is our next target. And for this, the most commonly used drug is insulin, which drives the potassium intracellularly. And usually we use a very rapid acting insulin like Actrapid, around 10 to 20 units, which is usually administered with 50% dextrose, around 25 to 50 ml, so that to avoid hypoglycemia while giving insulin. And usually it takes around 20 to 30 minutes to reduce the potassium. And with this dose, it can reduce at least up to 1 millimoles of potassium, serum potassium value. Another method, again, which we use to drive the potassium intracellularly is beta agonist like salbutamol. But here, when we give salbutamol, at least we give 4 times the dose of the usual one, which we give for nebulization for bronchodilation. So if we are using 2.5, we use around 10 milligram of salbutamol as nebulizer for driving the potassium intracellularly. Another drug which we may use is sodium bicarbonate, around 50 to 200 millimoles of 8.4%, but it's only used in conditions where there is severe acidosis related hyperkalemia. Only then usually it works best to drive the potassium into the cells. Now, the last method of treating hyperkalemia should be targeted towards eliminating the excess potassium in the body. And for that, we can use resins like calcium resonium. The dose is around 15 to 45 grams orally, which is given along with lactulose, which can bind to the excess potassium in the large intestine and can be excreted through the stools. And then the another thing what we can do is a potassium losing diuretic, like the loop diuretic, the furosemide, around 20 to 80 milligram can be given, but considering the blood pressure status of the patient, it should be given very cautiously. And last, but the gold standard treatment for hyperkalemia, especially in patients like this when they come into the intensive care unit, is hemofiltration, where we can remove the excess potassium in a much reliable way, and it can lower the potassium by around 1 millimole in the first hour. And usually in such severe hyperkalemia, we tend to go in for hemofiltration if the other methods doesn't work immediately.
Okay. So can you describe the coronary blood flow or coronary arterial blood flow?
Okay. So the heart receives around 5% of the total cardiac output as blood supply through the coronary vessels. The coronary arteries arises from the ascending aorta, just superior to the aortic valves. Now, it is divided into two, the left coronary artery and the right coronary artery. Left coronary artery arises from the posterior aortic sinuses, passes lateral to the pulmonary trunk and reaches the aortoventricular groove. And from there, it divides into two. One is the left anterior descending artery, which goes between the which goes through the interventricular groove and supplies the apex, the major part of the anterior wall of the left ventricle, and even 2/3 of the interventricular septum. The other branch of the left coronary artery is the circumflex artery, which turns around through the atrioventricular groove, goes to the lateral aspect and supplies the lateral aspect of the left ventricle. And the other major coronary artery is the right coronary artery, which arises from the anterior aortic sinuses, pass into the between the pulmonary trunk and the right atrium to descend into the atrioventricular groove. It supplies major part of the posterior part of the ventricles, the right heart, and the posterior interventricular septum.
Can you describe the venous drainage? Venous drainage of the heart.
Okay, so the venous drainage of heart is a bit complex. Around 1/3 of the venous drainage of the heart is through the small veins, or which are called the anterior cardiac veins, which directly drain into the right atrium. Nearly all other drainage is via the coronary sinus, which is located in the right atrium, just beside the inferior vena cava. Tributaries of the sinuses include the great and the left marginal veins, which follow the left coronary artery, and the right marginal, right middle, and small veins, which follow the course of the right coronary artery. Very small proportion of the venous drainage happens to the Thebetian veins, which drains directly into the left side of the heart.
Okay. Can you tell me what are the factors which controls the blood supply to the heart?
Okay, the blood supply to the heart is dependent on the contraction of the myocardium during the cardiac cycle, the patency of the coronary vessels, autoregulation, metabolites, then autonomic nervous system, and blood viscosity, and drugs, certain drugs.
Okay. Can you tell me how to measure the coronary blood flow?
Yes. So the coronary blood flow can be measured by the major method which I would like to describe is the fixed principle, which can be used into this. A fixed principle describes the fact that the amount of tracer substance taken up by an organ is equal to the product of the blood flow through the organ and the difference in concentration of the substrate across it. That is, flow is equal to uptake of the substrate by arteriovenous difference. This method can be performed using nitrous oxide or argon. It requires coronary sinus catheterization to estimate the tracer. The other method can be, which can be used to measure the coronary blood flow, is the thallium scanning, which may indicate the differences in the regional blood flow. And one more method is the thermodilution method, which can be used to estimate the coronary sinus flow, which measures the difference in the temperature.
Okay, the time is up. It is 15 minutes session, and the 15 minutes have ended. That was a nice session. So now Dr. Ashwini sir will be the examiner, and Dr. Gurikbal Singh will be the examinee.
Can you share that question?
Yeah, 1 second.
Sir, you're sharing?
No, 1 second.
The question.
I'm not.
I'll do it.
You can. I'm sorry about it.
No issues. So
thank you so much.
no issues, sir.
Okay.
The session is starting at 9:41. So
Okay. Hello, Dr. Gurikbal. So your exam session starts now. So the question is, what do you understand by terms anatomical and physiological dead space? And what is the relevance in anesthesia in a normal patient and in respiratory disease? And how can you measure the anatomical and the physiological dead space?
So anatomical dead space is the volume of the gas in the conducting airways, which doesn't take parts in the exchange of gases, while physiological dead space is sum of anatomical and alveolar dead space. Alveolar dead space is the gas in underperfused or non-perfused alveoli. The anatomical dead space we measure by the Fowler's method, where the patient is asked to exhale 100% oxygen at the end of expiration, and then he's asked to slowly exhale it into a nitrogen analyzer, and a graph of end tidal nitrogen against time is obtained, which has 3 phases. In phase 1, the nitrogen will be coming from the conducting airways. In part 2, there will be slow uprising of the slope because of the nitrogen coming from the conducting part as well as from the alveoli. And third will be a plateau phase where there will be slight upward slope because it will be a gas coming from the alveoli. While physiological dead space, we measure by Bohr's equation, which is Vd by Vt is equal to it's a difference of arterial partial pressure of carbon dioxide and end tidal carbon dioxide divided by arterial partial pressure of carbon dioxide. It's normally around 1/3 in a normal patient. And the dead space, usually the significance is that with the general anesthesia, the dead space is increased. The positive pressure ventilation increases the dead space. Positive end expiratory pressure would increase it. And the various respiratory diseases like in COPD patients, emphysema, ARDS, the dead space is increased, and also the breathing circuits will increase the dead space. So we have to choose the correct size of the breathing circuits and HME filters because they add to the dead space of the patient. Then endotracheal intubation will decrease it, while in supine position, the dead space is more in comparison to the sitting position. Jaw thrust and neck extension will increase the dead space. Yeah.
Okay. All right. So what are the effect of the PEEP in that to the dead space like?
So PEEP will increase the dead space.
Okay. Okay. So next question is, so what is obstructive sleep apnea?
It's a sleep-related breathing disorder, which is characterized by repeated episodes of apnea and hypopnea during the sleep.
And what is hyperapnea?
It's a reduction in the airflow by 50% for a period of 10 seconds during the sleep.
And what do you think will, the causes for the obstructive sleep apnea?
It's because of increased redundancy of pharyngeal wall. Usually the apnea occur because of the pharyngeal airway collapse.
And in which patients, in what kind of patients you expect obstructive sleep apnea?
So we
and
expect
what should be our target when we do a pre-anesthetic checkup?
Yeah. So we usually see in morbidly obese patient with a high BMI, with age more than 50, or with more neck circumference in male gender, those with the craniofacial abnormalities. So we have the stop bang criteria, where S stands for snoring, T for tiredness, O for observation of a stop breathing or gasping during sleep. P stands for increased blood pressure or hypertension. B is for BMI more than 35 kg per meter square. A for age more than 50 years, and neck circumference more than 17 inches in male and more than 16 inches in female, and G for the male gender.
Okay. And can you tell me about apnea hypopnea index, AHI?
So it's an index of total number of complete cessation of breath, that is apnea, and partial cessation of breathing, that is hypoapnea, occurring per hour of sleep.
And apnea should be like the time?
10 seconds.
Okay. And how do you grade the severity by apnea hypopnea index? Like,
so if
AHI.
apnea hypoapnea index is of 5 to 15, then it is mild. If it is 15 to 30, it's a moderate severity, and more than 30 is severe disease.
Okay. And in a pre-op evaluation, what other comorbidities would you suspect in a patient with obstructive sleep apnea?
Yeah, so these patients are prone to have the cardiovascular diseases. So we'll search for hypertension, coronary artery diseases in these patients.
Okay. Okay. So can you tell me about the sphincters of the gastrointestinal tract?
Yeah, so there's an upper esophageal sphincter, lower esophageal sphincter, pyloric sphincter, ileocecal sphincter, sphincter of Ojai, and anus.
And what is the upper esophageal sphincter made of?
So it is a cricopharyngeal part of inferior pharyngeal constrictor muscle. Okay. And
yeah,
and lower esophageal sphincter is made of intrinsic circular smooth muscle at the lowest 2 to 4 centimeter part of esophagus.
And what is the nerve supply? Can you tell me the nerve supply of the lower esophageal sphincter?
It's applied by vagus nerve.
Okay. And okay. And what is the significance of the barrier pressure?
So barrier pressure, it is a difference of lower esophageal sphincter pressure and intragastric pressure. So usually it's around 15 to 20 mm of Hg is its normal value. So
the normal barrier pressure, right?
Yeah, normal barrier pressure. So if the value if it is 0, then there are increased chances of gastroesophageal reflux. So decrease in lower esophageal sphincter pressure and increase in intragastric pressure can lead to increased chances of reflux, like in pregnancy, full stomach, abdominal distension. They have a high intragastric pressure, so the reflux would be more likely.
And can you tell me some drugs that can increase the esophageal sphincter tone the low esophageal sphincter?
Drugs like neostigmine, D2
Okay.
antagonists like metoclopramide, cyclizine, succinylcholine.
And the drugs that can decrease the tone, do you know any drugs which can?
Atropine, glycopyrrolate, anticholinergics, dopamine, opioids, thiopental, and alcohol.
Okay. Thank you. Thank you very much. And I think that's the end of this session.
Thank you.
Thank you. So, so this is how basically this was just a brief kind of a thing. What we showed how the mock the Viva is conducted in actual EDAIC exams. So they will it is not exactly like they want the complete they want us to answer the whole questions, but as we discussed earlier, they basically look at what do we actually know about the topic as a whole, and how safe are we as practitioners, and how much we know about the basic concepts in the anatomy, physiology, or pharmacology related to anesthesia and intensive care. Do you want to add anything, Gurikpal?
Yeah. So basically, we have to stick to the basics, because someone is asking about the ICU topics. So ICU topics, mostly like I got ecstasy poisoning during my session. My other people got aspirin poisoning. So one poisoning they would definitely ask. Along with that, they would give you some X-rays of maybe pneumothorax, consolidation, pneumonia, effusion, or we had an echo image of RV dysfunction. So those images are also important. ECGs they can show. So that is what is being asked in the ICU part, but still we have to stick to the ABC of anesthesia, and which basically they want to know that you can give a safe anesthesia.
So,
in case
and
of
even
ICU,
they can go into topics which we have not regularly practiced in our day-to-day things, or drugs which we are not used in places where we practice, but still we are supposed to know it, because after all, it's an exam which we are appearing. So yeah, because I was asked about remifentanil at that time in India. I mean, we were not used to it, but still my one question was labor analgesia using remifentanil. So they can ask any kind of latest updates on things. So
they asked me about the non-technical skills of anesthetist. They asked me about ERAs. They asked me about opioid-induced hyperalgesia, and if the patient is having chronic opioid and come to you for some surgery, how would you manage the pain in such kind of patients? So the level of question could be from very basic to the most recent and advanced one.
So they come. We should not forget reading about pain. And in case of ICU, we should also concentrate on sepsis guidelines, ARDS and ATLS guidelines, and pancreatitis, and any patient who has got an acute dyspnea, like how to differentiate between a respiratory cause and a cardiovascular cause. That is the question which I got. A radical cystectomy patient had an acute dyspnea. So whenever you answer a question like from the a patient is given, so you always start from, see, I'll assess the patient airway, breathing, circulation, vitals, blood pressure, and all that you say, and then you go in managing for the individual causes. So you just don't jump into like when they asked, I said I'll address the patient that I'm so and so, and I'll see for the vitals, respiratory rate, and I went up to, I'll see for the ultrasound rung, I look for echo to find out what is the difference between, like, if it is a cardiac cause or a respiratory cause. That's how it went. So once when you go in the flow, they'll stop you in between and they'll drag you into the way they want their questions to be asked. It's not like 100% you should answer that question and then they'll jump. You start answering that question. Once if they have got the particular answer, they will even switch to the next question. So there were no questions from There were mostly they don't concentrate on questions from physics, and in emergency medicine that they cover in the ICU part as well. And pain they have asked mostly from the primary podcast, which like most of it is from the primary podcast, like chronic hypersensitivity and pain, chronic pain, and how do you manage a patient with shingles and all that.
And they do ask about antibiotics as well. So like they ask minimum inhibitory concentration and which antibiotic will you give in this particular patient with renal failure and etc. etc. So they will ask questions about antibiotics for sure.
Okay.
So shall we tell about the books, a little bit about the books to read for EDAIC Part 2? So yeah, podcast, primary podcast and podcast for the final FRCA, those two are must, which you must read before going to the exam. And another is MasterPass. One is on physiology and the second one is on pharmacology. Physics, they would not ask. So MasterPass and podcast are something which is must. So,
and
Yeah.
Sir is speaking, but he's not audible. He's on mute.
yeah, sorry. Okay. Am I audible now?
Yeah.
So what I was trying to say is the exam pattern, the questions, the books we refer is a bit different from the MD exams, which we use in India. So like Dr. Gurukbar Singh said, the books like podcast, MasterPass, which should be stressed more, and for the illustrations for the waveforms, or more questions about physics and all, we can depend on for the graphs and all, we can depend on Plunkett, and basically we should have touched almost everything. So I think podcast and MasterPass is like a must read books. What do you think? Yeah.
Yes, the
Yeah,
podcast
podcasts
and
are must.
MasterPass is a must. Either one of
Yeah,
it,
must.
like primary and final, if you can read, and that will give us answer to most of the questions they ask.
Yeah. So in the clinical anesthesia, they can give any pathology. Like I got a question on a patient with obstructive jaundice with deranged LFT, and the patient was posted for some femur surgery. So any question on that can come, and then they can jump to another entirely different system.
Sometimes if you're lucky, you get very just a direct question. Sometimes you get really complicated things. So it all depends. For me, the ECG which they showed me was an atrial fibrillation. But again, some of my friends who appeared that day got some really tough things. So it all depends. And for me, the first session, which related to the basic science, my first question was cardiac cycle. But they ended up asking me about hyponatremia in that same session. So it began with cardiac cycle, but the session got over with hyponatremia and hypernatremia. So they can just ask. So one thing again I want to stress is, if we don't know an answer, like we don't know anything about that topic, just tell them that we don't know, because then they can jump into the next question. So because they have already prepared certain questions that they are going to ask us. So give them time to finish off their question, so that at least the next, if you don't know one question, the next you will know it much better, so that creates a good impression on the examiners.
Also the pharmacology part, there's a limited topics in terms of pharmacology, pharmacokinetics, dynamics of the drug, and that competitive antagonism, agonism. So one question, one session would be entirely of pharmacology. So we can do really well if we are thorough with pharmacology, because the topics are very limited and you can perform well in that session. The first 10-12 topic chapters in master pass in pharmacology one, that we must go through, because I was asked the opioids, the whole pharmacokinetics, dynamics, and different routes of administration of opioids in that session. So one question would be like that.
So another thing is we should always have, like today we had hyperkalemia and electrolyte disturbances. They surely ask one of it in the basic science, and they also concentrate on the anatomy. In the basic science, one of the question will be from anatomy, say the sacral plexus or a femoral plexus or a femoral nerve anatomy or larynx anatomy and recurrent laryngeal nerve. Tell something about recurrent laryngeal nerve and sorts. And like in case of pharmacology, you will also be touched upon what are the effects of, say, a patient with chronic liver failure and what are the effects on drug metabolism. And whenever you illustrate a drug, they may take that particular drug and ask what are its effects when the patient has got a CLD or a chronic renal disease, like that. My clinical session was about the COPD patient with the multiple comorbid illness, the CA lung posted for humerus fracture. So whichever anesthesia mode you're comfortable with, then you can go and tell. It is not like whatever they are expecting. It's like how you will anesthetize that particular patient. You should narrate that answer, whichever you're comfortable with. And that from there, the session went from anesthetizing a COPD patient to hyperkalemia, then to pituitary adenoma. So the session will go on and on until the time is finished. So when I didn't know the answer for what they asked, and another thing which we should not forget is learning about patient's blood management and massive blood transfusion protocol. We always tend to forget that ifs and buts, like plain patient blood management, massive transfusion protocol. And as Gurigbal said, most of the questions will revolve around pharmacology in the second session. And if you can read pharmacology well, then that second session is well taken care of. I said I'll anesthetize the patient with the supraglottic airway because the patient, the patient was not able to lie down. That's what the question had. The patient was not able to lie down, and the position of the surgery was not given. So I told the position of the surgery will differ from supine, lateral, and V chair position. I'll discuss with the surgeon as to what he's going to do and how he's going to fix the humerus. Since it is, and they said she was a smoker as well. So since it is a pathological fracture, I cannot optimize further. So I'll take up the patient as an emergency to fix the humerus. And I said I'll anesthetize the patient, put the patient on supraglottic airway. They asked me if I'm comfortable with the supraglottic airway in a V chair position. I said I'm using it and I am comfortable. So that's what I said. And they said, okay, you're using it, then it's fine.
And also,
they asked me if I want to intubate the patient. I said, no, I won't. It's okay. It's
exactly.
Good with the supraglottic airway. So I'm good to go with the supraglottic airway, and I use supraglottic airway. I will take care that the V chair position does not affect my hemodynamics as well. And if the hemodynamics are okay, then I'll go with V chair position. If at all it is hampering, I'll think about this, what I should do next once when the patient lands up in the particular problem.
That's what I think. In the clinical scenario, they will just walk you through the scenario. And literally they just let you describe exactly what you do as an anesthetist, and they just observe, as long as you don't do any blunder mistakes in the steps. I think it's all fine. So
they're very particular with the induction drugs and which muscle relaxant you will give, especially in that part. They will specifically ask, okay, why would you use vecuronium? Why would you use etracurium? Why would you use this particular induction agent? So we have to be very thorough with the induction drugs and techniques.
We should have a reason. When we tell an answer, we should have a reason for that. So that's what.
Because if we are doing some blunder, it's a big mistake.
Yeah. Then the next question was like, a chronic renal disease patient who has given Saxa and the patient has a bizarre ECG complex. What we'll do, you are called for help in the next OT was my next question. So whatever sir described, the causes of hyperkalemia and treatment of hyperkalemia, they just walked me through how will you treat hyperkalemia in that patient. So I just
because hyperkalemia is something which is very important, because even in the ICU part, I got the question on ecstasy poisoning. They went into the whole supportive care which is given for it, and eventually they asked me about hyperkalemia as well.
So electrolyte disturbances, we should not forget that question.
So they
and,
in that ecstasy poisoning, they went to the treatment of hyperkalemia, ECG changes, till the dialysis and everything.
Even I had got the question hyperkalemia in the first session itself. So then in the third session, that was for the intensive care, my question was all related to a patient who after intestinal obstruction went into sepsis and taken into the intensive care, and he had to finally went into AKI. So what will be a treatment? So basically they wanted me to end up in renal replacement therapy and tell about the modalities of renal replacement. So finally that's what they wanted to know, and the different CVV, HDA, all those things they wanted to know about everything about renal replacement therapy. And the first that 12.5 minutes of my session was only about renal replacement therapy they were concentrating on.
They also asked me about different modalities to induce hypothermia. So, so ICU session can go anywhere in the ICU care. Maybe it can go into ECMO, it can go into RRT, it can go into the basic ICU care.
So even in I think in podcast, the last part, there is some chapters about intensive care. In that, the renal replacement actually. When I was answering about renal replacement, that was the only thing which came into my memory at that time. So whatever I read apart from that, all I forgot. But whatever little I could say about renal replacement was from that book. So it at least 1 or 2 books, as we said before, we should be thorough with. Then rest all extra reading can be handy. That's all. So otherwise, we just go on reading from different books. Finally, we won't be able to revise, because revision is very important before going to the exam. At least 2-3 times we should know the topics which we have learned thoroughly. Otherwise it will be all like informations will be scattered here. At that time we won't be able to gather it and make it in one particular answer.
Yeah, in my session for all of us, they had asked about an ICU scoring system like Apache, Q, SOFA, and they asked me about RCRI and ASA grading, and they also asked about the scoring systems which are used in anesthesia as well, like Goldman, Detsky, like cardiac patients for non-cardiac surgery. What are the scorings you will use? What I was asked about.
And dexmedetomidine is also one of the good question, because they asked me dexmed, and I think you were also asked about dexmed in your sessions.
Clonidine, I think it's time and we can end the session now. Whatever doubts, whichever you have, you can put up in the group which we have formed. And this is how the Viva goes in the examination as well. That is all for today. Thank you all for
thank you
very much. Thank you
Guripal. Thank you Ashwini sir. Thank you all.
Bye.
Bye.